Nick Majerison here. Welcome to Top Med Talk. Now, before we get cracking, Top Med Talk is going to be at the International Fluid Academy Day on November the 23rd in Amsterdam. Full details, topmedtalk.com. Click on the section marked Events. You'll be able to find out more. It's on November the 23rd. It's in Amsterdam. It's the International Fluid Academy Day. Going to tell you more about that towards the end of the podcast. In the meantime, it's time for today's Top Med Talk. No elective surgery if hematocrit is less than 36. How can you get started? It's about standing up a preoperative anemia clinic, and it's part of the perioperative practicum, and it's part of the EBPOM USA Masters Course series. It's about standing up a preoperative anemia clinic. It's part 3 of 3. That means we've got 2 podcasts before this, which make this into a complete talk. It's Laurie Heller giving her talk at the EBPOM USA Masters Course, which of course took place earlier this year, April, in Atlanta. It was streamed live on topmedtalk.com. It makes for a fascinating talk. Have a listen. I'll give you some words at the end.
Top Med Talk.
In 2014, we opened an anesthesia clinic, and so a pre-admission clinic run by anesthesiologists. So now we still have our pharmacist in there helping us get pre-authorization, and we treat all of our pre-surgical patients, so every patient coming through. And this is what happened early on. So this is for our orthopedic patients transfused. We went from about a 60% transfusion rate down to 8% in a year. And this is looking at just following up from there, transfusion rate here from 8% down to 2% in 2013. And so where do you start? Well, the most important thing is you need administrative buy-in, right? Before you do anything, you need to get them on board with what you're going to do. And then you need data. So you need to somehow get some data out of Epic is a good mining tool. There are other sources out there, Humanetics. There's a lot of companies out there that can help you get data from your electronic medical record. And it's important to know that even if you just look at the cost of transfusion, as we know, it's sort of the part that you can see. Each unit of red cells is anywhere from $250 to $500. But what you don't see is that whole clinician time, the waste that occurs. Many of the administrators don't even know that in a lot of our DRGs, like for hips and knees, that includes payment for 2 units of red cells. So if you give them 2 units, that's already included in the global fee that the hospital is getting. And so they're going to be saving money if they're not transfusing those red cells. This was our data that we got initially to hopefully to talk our administration into doing this. But we looked at our percent transfused in the different surgical specialties, CT surgery, medicine ICU, oncology, and orthopedic surgery. And then we were able to show them that these aren't matched in any way, and these are just observational data, but patients with transfusion, their length of stay was higher. This was a big seller for our group, for our administration, and without transfusion, much lower length of stay. These are our complications that we just looked at grossly. So this is MRSA with transfusion, respiratory complications, renal complications, post-op infection, and C. diff. And this was enough to sell our administration on that. So we got administrative buy-in. We decided to target the orthopedic hospital again because of that opening of the hospital and because they have set DRGs. And then we started to look at the problem, the day of surgery pre-op crit, and we found it was pretty surprising. So the percent of the orthopedic patients already anemic were 60% of our patients coming in, so much higher. And that was because we were doing a lot of autologous donation, and so patients were giving their blood the week before and coming in anemic, which is not how you should do it, so we got rid of those. And then these are our CV patients. So when the CV surgeons heard we were doing this with orthopedics, they wanted to get on board, and our CV patients, percent anemic, were quite high, about 30%. And then you had to get the department buy-in. So we sold the administration on that we really need to fix our orthopedic department, and then you had to get the orthopedic buy-in. And with that, we showed their specific infections and complications. The blue bars are patients who were transfused in their infections and complications, and the green bars are not transfused. We were able to show that to the department and get them on board. This is just looking at drug-resistant infection like VRE and MRSA, post-op infection. And then we established our thresholds. And we used the thresholds. We used 36 for our patients, so men and women. But your centers may be different. These were our financials. We did a pilot study of 87 patients, and we just wanted to prove that we weren't going to lose money for the hospital. So this wasn't super robust, but we generated about $85,000 in 6 months, and we had a net profit of $5,000. Not a whole lot, but we were able to show that we weren't losing money for them. And that was sold. This is a study that was just published in 2013, but it estimated there's a $700 million savings just with elective spine procedures if you treat their preoperative anemia. And this is data you can share with your hospital. So setting up the clinic. So for a clinic setup, and we'll talk about more in this small group discussion, but you need some sort of mid-level. So there's a lot of calls that need to be made between these patients and the surgeon's office. Did you come in for your iron transfusion? Did you come in for your EPO? And following up and making sure patients meet the goals. So the mid-levels are helpful for that, and our pharmacist does that. You need a medical director. You need extra staffing in your infusion center. So your infusion center is used to doing chemotherapy and things, and now we estimate about 60 patients a month are getting IV iron and EPO infusions, so they had to up their staffing. You need to have your lab on board. You can't be waiting days and days for your iron studies to come back, and you need to have basic office setups. This is the workflow that's in your slides. I just included it so you would have it in your slides, but this is from Duke Medical Center and kind of walks you through what they do from start to finish as far as identifying patients and getting them through to surgery. And then this is our referral form. So all of our things are based on how do we make this easy for the surgeons. And one is just they have to fill out a form. And basically the form says when is their surgery and what is their surgery and who's their surgeon. And that's all we really need to know. Our clinic is just a virtual clinic. Patients don't come in. So the pharmacist will look at their labs. We call the patient. We don't actually have to see anyone. And even that, if surgeons don't fill out the form, all they even have to do is just call us and let us know that these patients will need anemia management. Since we've been doing this for so long, we've now evolved, and now we have, actually Swedish has our standard. So it's our standard that all patients coming in for surgery have to have a crit of 36. And so it's helpful for our surgeons, so when they get their surgery canceled the day of surgery, we just refer them to our Swedish standard and our Swedish guidelines. And we have lists of the patients, the high-risk surgeries that need to have that. Everyone else, we don't. So for minor surgeries, other than C-sections, we're happy with crits less than 34. But other than that, they need to have a crit of 36. So what do the financials look like? So our full-time pharmacists, we pay about $110. There's a medical director. It used to be about 20 hours a month. We're able to lower that now that things are up and running, about $50K a year. Supplies run about $10K a year. These are the drug costs for visit. And some of that is recoupable. I just pulled some data from 1 month of our ambulatory treatments, and we billed in a month $254,000 for, and of course our what we reclaim on that isn't quite as high. We got about $67,000, which is about a 30% return rate, which is pretty good for the hospital. And this is all profit made by our infusion center. So back to the case. So this patient here, and we talked about having an elective hip. So, and the one thing that you might want to notice, see how he's on this proton pump inhibitor, and this is probably why he hasn't been absorbing iron. He might have had a procedure before. His crit is 33.6. Do we proceed? So at Swedish, we wouldn't. We wouldn't proceed with this case. If they come in the day of surgery, we would say, sorry, we can't do your elective case. And what we would do is so the patient, it's frustrating for the patients to have their surgeries canceled, so we try to do something for them, and that is we send their iron studies then. We might give them a dose of IV iron before they leave so they feel like something's being done for them. And we would watch them, and we would have our pharmacists follow up with them. If they aren't meeting their goal, we might investigate further. They might need EPO, and we will reschedule their surgery for about 3 weeks. So because we've had to cancel a few of these surgeries, that doesn't happen all that often now, and now the surgeons know, and so we generally see them in our anemia clinic. But it does take canceling a few surgeries before you get surgeons to really come on board. So in conclusion, preoperative anemia is a risk factor for poor outcome in both short-term and long-term. We should evaluate and treat our preoperative anemia. IV iron is the mainstay of therapy. ESA is appropriate in some situations. Strong for surgery includes our glycemic management, our blood pressure control, and our anemia management, and it's a financially viable option for you in your hospital.
Part 3 of 3, that is. Now, the first two parts, the first one's called Preoperative Anemia is a Risk Factor for Poor Outcomes, and the second one is called Treating Pre-Op Anemia with IV Iron is Safe and Effective. Those are the two previous parts of this piece, which you need to have a look for on your podcatcher. Make sure you have a listen to those. And I mentioned at the beginning of the podcast, we're going to be covering the International Fluid Academy Day on November the 23rd in Amsterdam. Now, this is a great opportunity for you to meet the team if you want to come along. All you need to do is check out the website, topmedtalk.com, click through to events, and you'll find a full piece on the website detailing everything you need to know about the International Fluid Academy Day, November the 23rd. Now, we've set up a Slido account for people who want to interact with us and our guests during the International Fluid Academy Day. Here's how you get to that. Go to slido.com. I've got a login for you. It's hashtag TMTIFAD18. So IFAD, International Fluid Day 18, and TMT, of course, standing for Top Med Talk. So that password, once again, slido.com, hashtag TMTIFAD18. So TMT IFAD 18 is an easy way of remembering that. You can get onto there, put your question in early and have a chance of having it answered sooner rather than later. Don't forget that login, TMT IFAD 18. That's hashtag TMT IFAD 18, and that's on slido.com. And then, of course, if you think you can come along to the day itself, that'd be great. We'd love to see you. Amsterdam, November the 23rd. Go to the website, topmedtalk.com, and click on the section marked Events. Also, of course, you can download our full back catalogue at the moment here on Top Med Talk. All you need to do is go to your podcatcher and click Download All, or scroll through them individually and clicking Download on each one, or go to the website, topmedtalk.com, and explore our back catalogue, downloading as many as you can. It's entirely free. You can get all of the back catalogue at the moment. We're currently sorting through it, so it may not always be available in that form. So get yourself to the website, topmedtalk.com, and download all of our podcasts, our entire archive, whole back catalogue, many hundreds of valuable podcasts with incredible information within.